Let's turn our attention to therapies, which I've already spoken about, but strategies that could improve cardiovascular outcome. So in general, in people with diabetes, especially if they have known complications, an ACE inhibitor or angiotensin receptor blocker tends to lower the risk. And people with an MI beta blocker should be continued about 3 years after the event. In stable heart failure, you can use metformin, obviously not in the acute care setting. Dose metformin according to GFR. So you reduce the dose if it's less than 45 milliliters per minute and stop metformin if it's less than 30. And as I mentioned, in patients who have established cardiovascular disease or kidney disease, your first go-to drugs will be an SGLT2 inhibitor or a GLP-1 receptor agonist, whatever can be tolerated, afforded, and that the patient finds acceptable. Okay. So here, just a summary of the FDA cardiovascular outcome trials. And this would be a couple of lectures in themselves. So I've just summarized this. So as far as DPP4 inhibitors like sitagliptin, saxagliptin, they're all neutral. There was no significant impact on cardiovascular outcomes. But studies that looked at GLP-1 receptor agonists found benefit with liraglutide, semaglutide. Exenatide was neutral, dulaglutide from the Rewind study, and albiglutide. Okay. And SGLT2 inhibitors across the board, there was cardiovascular benefit. And with the last study on ertagliflozin, it was non-inferior to placebo. So and even interestingly, in the heart failure guidelines, the European guidelines and the American Heart Association guidelines for heart failure, in people with diabetes, an SGLT2 inhibitor is recommended to manage heart failure. So big changes. I'm going to just skip these two slides, which give you some more detail on the GLP-1 receptor agonist and the cardiovascular outcomes, some more detailed statistics on hazard reduction, similarly for SGLT2 inhibitors. I'm just going to skip over those slides for now. Let me just go over COVID-19 and diabetes, because I know this is an area of great interest. Hundreds of papers have already been published in this area. So what do we know so far? And we know that there isn't enough data to show whether people with diabetes are more likely to get COVID-19 than the general population. But we do know when they do get COVID-19, they're sicker. They're 2 to 3 times more likely to be hospitalized and more likely to have critical illness or die. And the hazard ratio of disease severity and poor survival in multiple global studies is actually 2 to 2.3. So people with diabetes who get COVID do not do well. In the ICU setting, they're prone to infection and worse outcomes. Obviously, other comorbidities that go along with diabetes, such as hypertension, CKD, hyperlipidemia, even stroke and cancer, are associated with greater disease severity and fatality. And longstanding diabetes and those with type 1 seem to have worse outcomes. So it makes, so we need to think about, well, how do we manage people who have COVID-19 and happen to have diabetes? There's a lot of, interesting literature initially about, is COVID-19 responsible for new onset diabetes? That's really unclear, but of course we know that people with severe disease can have stress hyperglycemia. They can even develop ketoacidosis due to metabolic stress, insulin resistance, and poor counter-regulation. We also know that diabetes and uncontrolled hypoglycemia is associated with higher hospitalization mortality. So how should we control patients? Well, the general consensus seems to be that try to keep their blood sugars less than 180 milligrams per deciliter, because greater than that appears to be associated with worse outcomes. So how do we manage people in the acute setting? first screen for diabetes, because this could be somebody you've missed and they have diabetes or they have severe hypoglycemia, which you have to treat as diabetes. Measure blood glucose, electrolytes, and even ketones and beta hydroxybutyrate, especially if they're sick, hypotensive, or acidotic. Insulin is still the mainstay of treatment for COVID patients who have diabetes. Some of them have continuous glucose monitors, and some hospital systems are actually using the patient's CGM to check their blood glucose readings, because you have far frequent readings. I mean, every 5-minute readings if necessary. And that saves a lot of nursing time, a lot of PPE going in and out of rooms to check blood sugars. So if they have CGM, if they're on an insulin pump, we should use that, okay? Sulfonylureas, TZD should be avoided. As well as glucosidase inhibitors, SGLT2, because of fluid imbalance, polyuria. You'd avoid metformin and GLP-1s in critical care. ACE inhibitors and angiotensin receptor blockers, there was a lot of concern whether this would be harmful in COVID-19 patients, but their use does not change mortality or reduce, it doesn't worsen outcomes, and their use reduces mortality in hypertensive patients with COVID. Steroids are beneficial for patients who have respiratory failure or severe respiratory symptoms. And of course, you would still use them in people with diabetes. Yes, their blood sugar will go up, but then we just step up our management. A few words on continuous glucose monitoring. Right now, we have two systems, real-time CGM, which one of the most common systems is Dexcom, and that has a sensor which is changed every 10 days, and a reader. And at any time, and every 5 minutes, it measures tissue glucose. You can see trends. It can alarm when it's above or below a threshold, and you can see the effect of what you're doing. And it reduces the need for finger sticks, which really has changed the life of people with diabetes. The other one is intermittently scan. When you scan the reader over the sensor, you get the current glucose reading. And this trade name is Freestyle. The more newer versions are now actually monitoring blood sugar continuously, and you can also see that in the reports. And then there are professional devices which you use to train patients to look at your brittle patients over a 3 to 5 day period, and you can use a CGM for that. It gives very helpful reports, and this is a whole science now. The glucose management indicator is like a predicted A1C, depending on 7 to 14 days of blood sugars. What would the A1C be? It gives you time in range. So between 70 to 180, how much time is the patient in green? How much hyperglycemia? How much hypoglycemia? And all kinds of graphs and trends that are very helpful. But it takes time. The interesting thing is now we can actually bill for interpreting glucose values and making decisions using CGM. This is a study in older adults with type 1 diabetes, a randomized trial with 105 women, 98 men. These were people over 60 years old with type 1, A1C less than 10%. And they were randomized to continuous glucose monitoring or standard finger stick monitoring. And the outcome was to look at the percentage of time that the glucose values were less than 70%. And in the CGM patients, they spent less time in hypoglycemia than the standard glucose monitoring patients. And the difference between those was 1.9%. And this is very important because we now have, and this and other studies are showing that CGM works in older people and it can improve outcomes. Lastly, we'll talk about strategies to improve care process in the facility. Okay. So one of the big things is collaboration, interprofessional collaboration and leadership. So a thorough evaluation of the patient when they come in, as I've mentioned, Set up facility protocols if you can, protocols for how often blood sugars should be checked, how often should practitioners be notified, and discourage every medical team doing things differently. So I think if everybody's on board and these protocols are used for every patient, it makes life much easier. Hypoglycemia education and management and review of medication therapy is really important. So don't just look at labs, look at the glucose trends. You could start quality improvement projects and try to replace sliding scale insulin, reduce the frequency of hypoglycemia. You could pick on reduction of ER visits or foot infections for that matter for your quality improvement projects. Okay. And then transitions of care. That's another place where we can really do much better, because anytime a patient transitions across different care settings to the community or to a higher or lower level of care, this is a high risk time for somebody with diabetes. And you can see that many factors affect this. Not only are there medication reconciliation, there may be errors in that, brands of drugs can change, doses can change, and many people are involved in the care of this patient, including family members, PCPs, specialists, hospice workers, therapy, pharmacy, they're all involved in the care of these patients. And so when the patient transitions to another environment, expectations, medication reconciliation, a proper history is really important. And this is not only have we seen these problems as clinicians, but it's a costly problem, because people with diabetes seem to be more prone to rehospitalization. As it is, 25% of all hospitalized patients have diabetes. And in this day and age, length of stay has decreased. These are old statistics. And the 30-day readmission rate for hospitalized patients is much higher than for all comers. And what leads to these readmissions seems to be infections, heart failure, DVTs, GI bleeds seem to be common causes of readmission. So we really need to look and see what are the risk factors for readmission for people with diabetes. And the common themes seem to be poor health literacy, system of the health failure in the discharge process, health system failure in the discharge process, failure of expected protective outcomes, like a caregiver, a pharmacy that will deliver medications, enough nutrition, family support. So failure of that system. And again, other failures such as transportation, finances, so the social determinants of health, unable to make appointments, okay, and loss of control over the illness, especially if there are medical complications. So the people who seem to be at risk of readmission are Black race, odds ratio 1.16, older adults, male gender. People have difficulty managing medications. If they had an urgent admission, longer length of stay, which means more complexity, higher comorbidity index, lower mean A1C, and transfer from another hospital. So these are all the risk factors for readmission. And the themes for readmission you see in the upper section of the slide. So I created a sort of pre-discharge checklist for long-term care patients. So from hospital to long-term care, I felt that on the left-hand side, there should be adequate progress notes, especially consults, an accurate diagnosis list, a more current medication list, at least a glucose log from the last few days. It's not necessary to have everything. Important laboratory tests, imaging tests, episodes of hypoglycemia, and what can the patient do for themselves. Now, from long-term care to home or from hospital to home, all those things are as important, but it's really important to tell the patient when to take their insulin, what doses, when to take their medications, what is there confusion with brands, to clarify their medications, who's going to deliver the medications, what is their meal plan, who's going to come and see them, is home healthcare set up, when do they see their PCP, when do they see their specialist. So all those logistic preparations that, we would give people a handful of papers in the family when they're discharged from the hospital, and didn't really help them, make these appointments, set up the follow-up, give them adequate information, make sure the PCP was aware of what was going on. And that also led to readmission. So I think many health systems are trying to do better with transitions. And lastly, I just want to mention optimizing insulin delivery. So we were used to, first of all, how do you inject? It sounds very basic, but initially around 2010, the main recommendation was to angle the needle we were using fairly long length needles, 6 to 8 millimeters, and we were angling it. Now, unless the patient is very thin and very frail, you don't need to pinch the skin. You just go straight down and you reach the subcutaneous tissue. Now, obviously, you want to use short needles, 4 to 5 millimeters, you go straight down. We want to avoid intramuscular injection of insulin and a rush of insulin to cause hypoglycemia. We often forget to advise patients about site rotation. So patients often inject on one place on the thighs or right and left lower quadrant, and that area hardens, they get lipohypertrophy, they have less pain, but they also have inefficient insulin delivery. So I often joke with my patients and say, we've all got plenty of room to move our insulin injections around, one finger breadth at a time. And this picture just shows all the possible sites you could use. Now, obviously, if somebody is going to use a bicycle or a treadmill or something, try not to inject in the legs, or if they're going to use arm exercises, don't inject the arms because you could get a rush of insulin. And these pictures are rather exaggerated representations, but not changing and rotating insulin sites can lead to lipoatrophy, atrophy of the fat, or hypertrophy of the fat. And although this is very exaggerated, but you will often see lipohypertrophy if you run your fingers over the insulin injection sites. So it's always worth asking patients, let me see where you inject. Okay, I don't do that at every visit, but I think it's certainly worth every couple of visits to think about that. Okay, so I'm going to stop here, and happy to take any questions. And thanks so much for your attention. I told you it was a whirlwind tour. Thank you.